From Microbe TV, this is Infectious Disease Puscast, episode 60, recorded on July 31st, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. So I don't know about you, Daniel, but I'm obviously watching the Olympics. I pulled a little quote out because I thought this was relevant to ID folks. But one of the American, or actually I don't know if there's multiple, an American triathlete commented on, all of the information that's going on as far as E. coli and contamination in the Seine. And he said, "We know that there's going to be some E. coli exposure, so I just try to increase my E. coli threshold by exposing myself to a little bit of E. coli in your day-to-day life. Just little things throughout your day, like not washing your hands after you go to the bathroom." It seems like hopefully people have been giving him feedback that I don't think I would recommend as I don't think it's going to accomplish what you think it will accomplish, but
It is entertaining. I mean, I see the logic.
You can trace it.
I had a lady this week in the hospital, so we know this isn't going to go well. And the story was that her daughter worked at a big supermarket chain and had warned her not to buy cold cuts because of this listeria contamination.
Yeah, the Borsa.
So she explained to me, she said, taking my daughter's good advice, I decided not to buy any cold cuts. But fortunately, I had some sliced turkey that had been in the fridge well over a week. And so I knew that it was old enough that I wouldn't have to worry. But then when I ate it, she ended up with E. coli bacteremia.
Oh, no.
So she's all ready to swim in the Seine.
Yeah. So, it's nice to see little random ID things that just pop up. So I threw it out there along with, watching people get their medals.
Yeah, I have to start watching some of the Olympics. I just...
Yeah. Well, it's hard. Ever since they changed it where they move it into prime time. I feel like I miss when the Olympics just were continuously on at odd hours of the day and you could just log it, turn on your TV. I feel like you can't do that. But anywho, I'll direct us back. Podcast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right, and we will start off with viral. Remember to listen to This Week in Virology, both the deep dive and the clinical updates. And I have to say, this is we've got some exciting stuff here today. And this is the article. We always have exciting stuff, but okay. The article, Twice Yearly Lenacapavir. How do I pronounce that? Sara, what do you say?
Lenacapavir?
Okay, boy, that was easy. Lenacapavir.
I hope that's right.
We're going with that. That's it. Or daily FTAF for HIV prevention in cisgender women was published in the New England Journal of Medicine. So these are results of a phase 3 double-blind randomized control trial involving adolescent girls and young women in South Africa and Uganda. Participants were assigned in a 2-to-1 ratio to receive subcutaneous lenacapavir every 26 weeks, right? So twice a year, you're going to get a shot. Daily oral emtricitabine tenofovir, but it's the TAF, so the tenofovir alafenamide. That's every day. Or the daily oral emtricitabine tenofovir, like the standard stuff. That's the active control, kind of a standard pre-exposure prophylaxis. So we have these 3 arms. So, and all the participants are going to get injected with some placebo or take a placebo. So we're going to try to get everyone blinded here. So they're going to compare this. We've got 5,338 participants who were initially HIV negative, and they end up in this group. So 55 incident HIV infections, right? So about 1% of the folks are going to end up getting HIV. Let's see what happens. So the first is, what about those folks who just got a shot twice a year? 0 infections. 100% efficacious. Now, if you move to the different groups that are getting the different oral forms, you're seeing about 2 per 100 person year, so 2.02 and 1.69. No safety concerns were found. 4 participants in a lenacapavir group discontinued the trial owing to injection site reactions. That is a 0.2%. So over 2,000 people, 4 of them had some injection site reactions. And so I want to step up on my soapbox here and talk about why this study is so important. And you know, Sara, I just listened to a very timely febrile episode, something about PIP, PrEP in your pocket. But so maybe we can even expand a little bit. Cisgender women account for approximately half of the 1.3 million new HIV infections that happen each year. And I'm going to point out 1.3 million new HIV infections each year. There's no reason that this could not work in the other half of folks at risk for HIV infection. We do need the trials to be certain, but zero, no adolescent girls or young women receiving this twice yearly injection acquired HIV in this trial. I guess the other thing I should point out here is I've seen, and it's a bit embarrassing. They've been referring to this as a vaccine. It's not a vaccine. This is biochemical prophylaxis. This is basically an active medication. So all you anti-vaccine folks who are not listening to us, it's not a vaccine. It's just a medicine twice a year, injectable. You don't end up with HIV. And this really, I think, adds a tremendous tool, right? Because we have our PrEP, we have our pre-exposure prophylaxis. You pop your pill every day, but unfortunately, we're still seeing, right, 2 per 100 person year infections, right? So basically, that's about a 1% failure rate, which is not great. We also, as you talked about in your episode, do you want to mention the other approaches, the 2-1-1?
Yeah. So we had Maxime Billick and Isaac Bogashier from Toronto who talked about the buffet of HIV prevention. So they talked about different PrEPs a little bit, like classic PrEP, like they compared, and here the 2-1-1 with anticipated sex, and then they talked a little bit about post-exposure, and then the focus was on PEP, which is post-exposure prophylaxis in pocket. So hopefully we actually didn't plan it, but it just happened that this came out like the week or a couple days before. So we didn't talk about this trial quite as much, but I think people have been working on different ways to provide PrEP, whether those are almost like implants, like Nexplanon, but obviously something like this would be amazing. You come in and get just get these shots and are protected from HIV. It's very exciting.
Yeah, no, I mean, and I'll echo what was on that episode. I think we underestimate what's going on and the dynamic nature of what's going on sexually for the individuals we interact with. How often someone shows up at an urgent care clinic for a miscellaneous thing, does the provider jump in and say, hey, by the way, are you sexually active? Are you, are you at risk? And we sort of have this bias like, oh, this is just certain communities and not us, not them, not my patients. But it's not true. We're looking at over 1 million new infections every year. We're looking at maybe 40,000 new infections every year in the U.S. alone. And we have tools. We have this tremendous data here. We have that 2-1-1. We've got your Truvada, or the fancy equivalent, where you pop 2 pills, sort of knowing that it might be an exposure, and then 1-1. You've got your, boy, I had an exposure within 48, maybe 72 hours. You start on your 28 days of 3 therapy, or you're, so got a lot of options out there.
Yeah, love it. Well, in another commonly mentioned virus that I feel like I bring a lot of CMV papers, but this one's from CID. It is an update. So consensus definitions of CMV infection and disease in transplant patients, including resistant and refractory CMV use for use in clinical trials. The 2024 update from the Transplant Associated Virus Infections Forum. So some things are unchanged. So the CMV definitions that most people hopefully are familiar with, like DNA emia, end organ disease, CMV syndrome, those are unchanged. They took the categories of refractory and probably refractory and consolidated them into sort of one description. So refractory CMV infection. And so that is CMV viremia, or depending on your testing, DNA anemia, antigenemia, that increases. So a greater than 1 log increase in the DNA levels in the same blood compartment, hopefully measured in the same lab or using the same assay, or a CMV number that persists, so less than or equal to a log increase or decrease in DNA levels after at least 2 weeks of appropriate antiviral therapy. And so this, I think, really mirrors what we sort of say in real life when we are seeing patients not really teasing out refractory or probably refractory. And I think the hope is that this could potentially improve clinical trial enrollment by consolidating those definitions. And then they give a little bit of info on definition of CMV antiviral drug resistance for use in clinical trials. And so resistant CMV infection is defined as that refractory CMV definition we talked about, plus a viral genetic alteration that decreases susceptibility to one or more drugs. And so when we send off that testing, mutations can be categorized as mutations that confer a known level of drug resistance, or sequence polymorphisms detected in isolates not previously exposed to antiviral drugs. So anyway, it's a relatively quick read, but those are the major sort of take-homes and updates that hopefully will help us get even more patients enrolled in future CMV transplant trials.
Okay. We have the article, Shingles Vaccine. The recombinant shingles vaccine is associated with lower risk of dementia, recently published as a brief communication in Nature Medicine. So there's some evidence that perhaps some dementia is associated with or even caused by VZV reactivation. Now, when people get the chickenpox reactivation, like the shingles, and you do a CSF PCR, many immunocompetent people with just a single dermatome involved can have positive CSF VZV PCRs. And I still remember that catchy article, Zoster on the Brain. I'm going to leave a link into that because I have to say, I was not something I was really thinking was the case until reading that article. So then perhaps getting that new, really effective protein-based single vaccine, shingles vaccine, can reduce the risk of dementia. 2 shots, of course, here. So here, these investigators used a natural experiment opportunity created by the rapid transition from the use of replication competent to the use of recombinant vaccines to compare the risk of dementia between the VZV vaccines, right? So the overall risk may be even better, we'll see, but this is moving to this more effective vaccine. They found that the recombinant vaccine was associated with a significantly lower risk of dementia in the 6 years post-vaccination. Really about a 20% increase in diagnosis-free time, 17%. The recombinant shingles vaccine was also associated with lower risk of dementia compared to 2 other vaccines commonly used in older folks. So it's not just a vaccine effect. So better than influenza, better than the tetanus, diphtheria, pertussis vaccines. And the effect was robust across multiple secondary analysis and in both men and women, but greater in women. All right.
Bonus. Vaccine bonus.
But kind of interesting, right? I really like this idea. And I'm sort of curious, maybe with the chickenpox vaccine, so people aren't going to get the chickenpox and they're not going to get the zoster at the same rate that we see now. Are we going to end up with less demented? So, hopefully our younger kids will take care of us in a dementia-free situation. All right. And I guess I'm sticking on this. So the article, Association of the Incidence of Postherpetic Neuralgia with Early Treatment Intervention of Herpes Zoster and Patient Baseline Characteristics, a systematic review and meta-analysis of cohort studies published in the International Journal of Infectious Disease. I thought it was very timely. Right? I was doing visits last night into the late hours. So it's about 9 o'clock at night. And I have this patient, and somehow shingles comes up, and she's like, "Well, I just don't know about that vaccine, because I could just take the medicine, and then I don't have to worry about postherpetic neuralgia." And I said, "Well, I recently read this article, so Let us go through the results of this meta-analysis looking at the association between post-herpetic neuralgia, baseline characteristics of patients with herpes zoster, and early intervention. So let's kind of get a little background here, right? So those of us that are old enough to have predated the chickenpox vaccine, we got chickenpox at some point in the past. The risk of reactivation and getting shingles is about 50-50 in your lifetime. It's really pretty high. And if you get shingles, then you might end up getting a vaccine because you're thinking I don't want to get my shingles. So you get it, and now your vaccine might reduce your risk of getting shingles by about 90%. But if you take that 50-50, you get that 90% reduction. Still not 100%. Now, what if you get shingles? What's your chance that you're going to get post-herpetic neuralgia? That's 5 to 30%, a little bit higher than I thought I realized. I mean, we get kind of a biased perspective because a lot of folks come and see us with that. But so here's the deal. How do I really get this down? So the folks here look at a total of 53 cohort studies, and what do they find? They find that the timing of initial treatment, so if you get that treatment in less than 3 days, then you're going to reduce the risk almost in half of post-herpetic neuralgia, and there are 5 studies that looked at that. Glucocorticoid use. If you get glucocorticoids, that looks like there may be a protective effect. So this may be about a 40% reduction, but really wide confidence intervals, right? So 0.22 to 1.70, so not sure. Only 3 studies there, so we need a little more data on that. In contrast, female, a little bit higher risk, certain locations like cervical or lumbar, and then being on immunosuppressive therapy can increase your chance of ending up with the post-herpetic neuralgia. So what do you do to really drop this down? Let's run those numbers. So if you have gotten chickenpox, 50-50 chance you're going to get shingles, a 5 to 30% chance that that's going to end up with post-herpetic neuralgia. Don't like any of these odds. So you get your vaccine, you get your antivirals within 3 days, and then maybe a short course of steroids is helpful. And I will say they have a really nice graphical abstract that really lays all this out. All right, well, we're moving into bacterial, and we're going to start with a little bit of a tag team here, but be sure to listen to This Week in Microbiology. And so pretty exciting, the IDSA 2024 guidance on the treatment of antimicrobial resistant gram-negative infections. I think you teased that this was coming out last time, Sara. And so we have the 4th updated guidance document focused on infections caused by extended spectrum beta-lactase producing Enterobacterales, AMP-C beta-lactamase producing Enterobacterales, AMP-CE, carbapenem-resistant Enterobacterales, CRE, Pseudomonas aeruginosus with difficult-to-treat resistance, DTR, I love that, carbapenem-resistant Acineta baumannii, crab, and Stenotrophomonas maltophilia. Right, so all this stuff was published in the idsociety.org practice guidelines site, so we'll leave in a link to that. But just to go through a little bit and sort of try to hit the high points, but Sara, you jump in and help me with this, because there's a lot in even just the bullet points. I mean, the bullet points are 2 pages,
Yeah.
So what about that ESBL UTI, complicated UTI? Fosfomycin continues to not be suggested for pyelo and complicated UTIs. So sort of think about that, but maybe we can throw it in there in a simple cystitis. Augmentin, amoxicillin clavulanic acid, continues to not be a preferred agent for uncomplicated ESBL producing cystitis. Little details on mechanistic reasons why pip/tazo is not anticipated to be effective for certain ESBL infections. And they say, this is what I'm hoping can help me tease out. So we've covered a little bit about sort of this rollback of not everyone gets carbapenems, but here they say pip/tazo continues to not be preferred for the treatment of pyelonephritis and complicated UTI. And I think they're making the distinction here between a pyelo, a bacteremia, a severe infection, and maybe just the simple cystitis.
Yeah.
I'm getting a good nod, so that's excellent.
Yeah. Well, I think I feel like the messaging was still the same, that if you find out after the fact that it's ESBL and they've been on Piptazo and they've gotten better, that, you probably could continue it, acknowledging that there is a chance that they could fail. But I know there's people have different opinions on like how willing they are to use Piptazo in that setting. But I think that they give you the flexibility that if your patient got better, even if it was on Zos, and that you could leave them based on some of the, papers that are out there that I can't remember. I think we did a example case like that in I have to go back to those episodes now. I don't think there were any big changes in sort of the overall message about can we use Piptazo or not. And then I guess I could go for AMP-C. I think a lot of the changes were relatively small. Like they wrote for those sort of several bacteria that are listed as clinically significant AMP-C, instead of saying moderate to high risk, they say moderate risk. They still, what else did they put? I'll just read from that bullet. The suggestion that cefepime is not advised for Enterobacter cloacae, Citrobacter fruendii, and Klebsiella aerogenes with cefepime MICs of 4 to 8 because of concerns for an increased risk of ESBL production in the cefepime MIC range was removed in light of newer data and a re-review of existing data. So opening up that's a little bit different from before.
Mm-hmm.
And I think I'm trying to remember. I like skimmed that. I haven't really sat down with that. I do think that they added sulbactam, durlobactam for an option with crab. I can't remember if it either wasn't mentioned or I think it was before some of the data and availability came out.
Yeah, they added as preferred is added as a preferred agent. So right under the crab section, and I'll recommend everyone read this because there's a lot in here. And I was managing a difficult patient the other day, and I'm like sitting with this open, like looking through it, sort of. But so crab, sulbactam, durlobactam in combination with meropenem or imipenem celastin was added as the preferred agent for the treatment of crab infections. High dose amp-sulbactam in combination with at least one other agent has been changed from a preferred to alternative agent now that we've got the sulbactam, durlobactam.
Yeah.
And boy, if you're going to use that high dose amp-sulbactam, they're adjusting it to 27 grams of the amp-sulbactam. So you end up with 9 grams of sulbactam, because here in the States, we can't just get the pure sulbactam like they can get like Australia, some other places. And then some nice updated comments on Stenotrophomonas multifila. And I think the big takeaway here that maybe not everyone is really on page with this is that you're really supposed to be using 2 agents initially in the treatment of Stenotrophomonas. So I know a lot of people, I still see a lot of monotherapy out there. But here we see questions have been adjusted to list agents in order of preference with a second agent, at least initially. And then they talk about the different options here.
I do think it's interesting because I feel like now cefiderocol is sort of listed as the sort of agent of preference with the second drug, which I don't know what other people's practices are. I don't know that how many people have been using cefiderocol as their sort of first agent if they had, for example, Bactrim and levo susceptibility or some, I know everyone's going to be a little bit different, but I'm I would agree. Surprised cefiderocol was the first one there.
Yeah, I would agree. I mean, most of the practice I'm seeing is maybe a minocycline, a fluoroquinolone, TMP sulfa, one of those 3 being picked with a second one of those 3. So yeah, the cefiderocol is still not widely used. So this will be interesting to see the penetration of these recommendations.
Yeah, cool. And then this next one, I mean, they get an entry in Puscast just because of the title alone. So in OFID Put the vanc down, flip it, and reverse it. Comparison of vancomycin and daptomycin healthcare utilization and cost in outpatient parenteral antimicrobial therapy. So this was a single center retrospective cohort study of adults who had received at least 72 hours of vanc or daptomycin, either via home infusion, an infusion center, or a skilled nursing facility. This was at OHSU. It included 290 patients who received vanc and 119 who received daptomycin. And the authors found that the vanc results in significantly higher healthcare utilization and a similar cost per course compared to Adapto and OPAT. There were no statistically significant differences in the rates of total events requiring intervention. And I actually just pulled out these two because this next 2 or 3 sentences, I feel like it's a perfect encapsulation of their message. So I'm just going to present that. So as represented in our data, patients with Medicare coverage are more likely to receive OPAT and a SNF, given that home infusion services are not covered by Medicare Parts A and B, thereby increasing the likelihood of receiving vanc, as SNFs, skilled nursing facilities, have historically rejected daptomycin on the basis of cost. Although daptomycin carries a higher medication cost, it requires less healthcare utilization in terms of additional labs, required care management by the OPAT team, as demonstrated by our cost analysis. So they're really just pointing out that there are significant indirect cost considerations separate from just comparing the cost of the drug itself. And, not to forget patient satisfaction of being on a daily med or maybe every other day, depending on their renal function, having a shorter infusion time, not having to get vanc testing. Lots of pluses there. So if the vanc wasn't going to get on the on Puscast, that title was clearly asking for us to mention it. And then I will mention one other one to close out this section that was from JPIDS, Durations of Antibiotic Treatment for Acute Otitis Media and Variability in Prescribed Durations Across 2 Larger Academic Health Systems. So backstory, the national guidelines recommend short, meaning 5 to 7 day courses of antibiotics for children who are over the age of 2 with acute otitis media, but most receive the sort of more classical, longer 10-day courses. So this study took a look at these antibiotic durations across 2 systems. About 84% of children in the study were prescribed some sort of antibiotic. Most prescriptions, and by most I mean 75%, were for 10 days, 20% were for 7 days, and only 5% were for 5-day durations. And then a quarter of the prescriptions were also for non-first-line acute otitis media antibiotics. So clearly a place where pediatric antibiotic stewardship programs could focus. And even though, it's obviously not as excited about seeing infrequent use of the 5-day courses, but I think it's helpful to really point out and show in the data that people are not doing those shorter durations. But it's interesting because the authors pointed out that there's a very specific subset, a small group within the clinicians that tended to be the prescribers of short durations. So trying to leverage those short duration folks as champions for shorter durations. And thinking about things like feedback with peer-to-peer comparisons also hopefully would be a good thing. So I think it's always impressive to see exactly how much. We always sort of say, oh, we do think most people do 10 days versus shorter, but to see it in sort of 2 separate places that most people are still doing the 10 days.
Yeah, I sort of worry, Sara. Who do you think's doing the shorter 5-day evidence-based? Who's doing the 10 days? Is it really the elder physician leader who is moving forward with the 5-day evidence-based, or is it the younger, fresh out of training, a little bit intimidated by the? So anyway,
Yeah.
You complete the sentence. All right, fungal. Fungal, when is the next season coming out? Well, the article, Adjunctive Single-Dose Liposomal Amphotericin to Prevent Cryptococcal Meningitis in People with Human Immunodeficiency Virus, HIV-Associated Cryptococcal Antigenemia, and Low Plasma Cryptococcal Antigen Titers, recently published in CID. Now, cryptococcal meningitis is a leading cause of AIDS-related mortality, particularly regionally, particularly in sub-Saharan Africa. And cryptococcal antigen predicts the development of meningitis. Now, historically, despite standard of care fluconazole, 25 to 30% of asymptomatic crypt antigen positive persons develop, they use this term, breakthrough meningitis or death. So here they're going to look at adding a single high-dose liposomal amphotericin B to standard preemptive fluconazole therapy with the hope that it might improve meningitis-free survival, right? So this is a no-brainer, right? Of course this is going to help. Why even do the science? Well, participants with HIV, asymptomatic cryptococcal antigenemia in Uganda were randomized to get this, the amphotericin B once with fluconazole or just fluconazole alone. They then compared 24-week meningitis-free survival time between the groups. And after the second interim review, the Data Safety Monitoring Board recommended no further enrollment due to futility. And this was looking at participants with the low plasma cryptococcal antigen lateral flow assay titers of less than or equal to 180. So let's look at what about these participants? Why did they decide there was a futility issue here? So we've got 168 participants enrolled into this trial with these low plasma titers. During 24 weeks of follow-up, meningitis or death occurred in 14.5% of the participants who got the liposomal amphotericin B and 10.6% in the folks that just got fluconazole. So not good. Adverse events were more frequent in the folks that got the amphotericin. Yeah, not helpful and possibly harmful.
Interesting. And then I have one from Transplant Infectious Diseases. I realize I did myself a disservice, though, to pick something that I should have checked on pronunciation, but I'm just going to go for it and someone can send me an email. I'll actually say it. Stagonospora cutaneous infection in a kidney transplant recipient, first described case in a human. And again, that's from Transplant Infectious Diseases. So this is a clinical correspondence reporting a case of a 75-year-old male who had a history of a deceased donor renal transplant in 2015, who developed this kind of unique cutaneous lesion, had a skin biopsy which showed filamentous fungal hyphae, and was ultimately identified as this Stagonospora via PCR and sequencing. The patient also had an elevated beta-D-glucan, which the authors sort of argue that this was a signal of invasive infection. He was treated with oral posaconazole with complete resolution in just 3 weeks. So Stagonospora is found in soil, plant debris, decaying plant material around the world. It is responsible for some diseases in agricultural crops, but as the title said, first described case in a human. So this sort of clinical syndrome or infection was representing phaeohyphomycosis, which is something that we still need to think about even in our solid organ transplant recipients who have unusual skin lesions. So I realize I should have put the picture that's in there. But anytime there's a first described case in a human, I'm going to try to pull into a Puscast. And then the other paper I have for fungal is from CID, European study of cerebral aspergillosis treated with isavuconazole, and EFISG study. So it's the ESCMID Fungal Infection Study Group in collaboration with the European Confederation of Medical Mycology, ECMM. So all the alphabet soup. So this was a European multicenter retrospective study of patients treated with isavuconazole for proven or probable cerebral aspergillosis between 2014 and 2022. It included 40 patients from 10 countries. 25 of those were proven disease and 15 were probable. and about half the patients had an underlying hematologic malignancy. Isavuconazole was provided as first-line treatment to 10 patients, which is about a quarter or 25%, usually in combination therapy at some point. And then about 70% of the cases resulted in sort of control of their infection. 30 patients received isavuconazole after a median of 65 days on another therapy, usually transitioning related to side effects. And then 17 of those 40 patients underwent some type of neurosurgery. So the isavuconazole levels were low in the CSF when measured, but adequate in serum and brain tissue. The overall 12-week mortality was 18%, which is honestly lower than I was expecting. It does seem lower than what has been in the literature as well. Could that be because some of the patients that were included had a less severe form or survived long enough to be able to be switched to a different antifungal, sort of a selection bias there? But if in the group of patients receiving isavuconazole as first line, their mortality was 30%, which still was relatively low. So it still seems like a signal that this is something that has a good safety profile, that patients are able to stay on the med for longer without interruptions. There's another study that they compared their results to called the Serial study, which is a great acronym. I will also pull out for the pediatricians, there was a very small subgroup of 7 children included that were aged in the range of 5 to 15 years old, mostly patients who had AML. I think it was 5 of the 7 that had AML. For those patients, the cerebral aspergillosis progressed in 2 children, with the addition of an antifungal drug helping lead to control of the infection in one of those 2 children. But there were no side effects, no treatment interruptions, and all the children were alive 12 weeks after introducing isavuconazole, although one died of progression of disease like 7 months after they were switched. So just a little bit of information on thinking about using isavuconazole instead of voriconazole in the setting.
All right. So parasitic, be sure to listen to This Week in Parasitism now every 2 weeks, a little more often than we were once. I'm going to put this up there with almost like our first one with more exciting news. The future's a little bit brighter than it might seem when you follow your Apple News feed, but exciting news reading the Helio article, Rollout of World's Second Malaria Vaccine Begins in Ivory Coast. So Ivory Coast administered the first doses of the world's second malaria vaccine the week of July 15th. That's my birthday, July 15th, just in case people send me presents, marking the latest development in a decades-long effort to control the deadly mosquito-borne disease. And so this is the R2 Matrix M, recommended by WHO for widespread use last year. It uses an antigen created at Oxford University in England and an adjuvant manufactured by Novavax. The rollout began in the Ivorian city of Abidjan and is expected to eventually include at least 15 African countries by the end of this year. The plan is to vaccinate approximately 6.6 million children in 2024 and 2025 using doses manufactured by the Serum Institute of India, which is offering the vaccine at less than $4 per dose. Very cool stuff. Yeah. All right, the article. This is great. I mean, I actually quoted this in the office yesterday. I was talking to one of my colleagues, but the article, Executive Summary, Evaluation and Management of Delusional Infestation, was published in CID. Now, this is a challenging and tough topic, but one where we really should be prepared and not dismissive, as these folks really are suffering. The paper aims to provide a framework for infectious disease clinicians in the evaluation and management of patients with delusional infestation. And so let me just a little bit from this article, but it's a short read. It's worth reading. The clinician-patient relationship is crucial to patient follow-up, compliance with recommended treatments, and is likely to influence the patient's prognosis. It is recommended to validate their emotional experience, but not their delusion. Now that's a tricky line to what's the expression, line to tread or something, but using language such as, we might not be able to find the bug, but we do have strategies to improve your symptoms, even if we don't find it. Documentation is an important tool that can be used to demonstrate the amount of thought spent listening to the patient and thinking about the differential diagnosis. And I have to say, these people, it's tough. These people are suffering. A lot of them, by the time they come to an ID doc, are engaged in self-mutilation. A lot of times they're basically told by the ID docs, I'm sorry, I will not see you unless I have an objective diagnosis, unless I have a confirmatory biopsy. And where did these people go? They end up often going to quacks, or they end up being lost and then just continue with this self-harm. So as clinicians, we went into this to try to take care of folks. These people certainly need care. And this is a nice executive summary that might help those that are willing to engage and help these suffering folks.
Yeah, it's all about having that right, like, language and framing it. I love taking how they describe it and trying to build that in. Yeah, so I'm working on the Febrile Star recording, so hopefully we'll have the authors of this and make an episode and talk more about some of these strategies. I'm excited.
Oh, that would be great. All right. The article, Parasitic Contamination of Soil in the Southern United States, published in the American Journal of Tropical Medicine and Hygiene. Now, parasites are generally associated with lower income countries in tropical and subtropical areas, but still they're also prevalent in low income communities in the southern United States. So here, a total of 499 soil samples of approximately 50 grams were collected from public parks and private residences in Alabama, Louisiana, Mississippi, Southern Carolina, South Carolina, and Texas. DNA from samples. They're going to go ahead and they're going to use this multi-parallel quantitative PCR, and they detected total sample contamination of, are you ready for this? Blastocystis, 19%, Toxocaricati, 6%, Toxocaricanus, 3.6%, Strongyloides, 2%, Trichuris trichuria, 1.8%, Ancylostoma duodenale, 1.4%, Giardia, 1.4%, Cryptosporidium, 1%, Entamoeba histolytica, 0.2%, Necator americanus, 0.2%. Overall, parasite contamination rates varied significantly between communities, with a high in western Mississippi, 46.88%, southwestern Alabama, 39.62%, just when I was considering visiting, northeastern Louisiana, 27.9%, southwestern South Carolina, 27.9%, South Texas, 6.93%. T-cati DNA burdens were more significant in communities with higher poverty rates, including northeastern Louisiana, western Mississippi, southwestern Alabama, and southwestern South Carolina. All right, so a little bit of close us out with a miscellaneous. And I think this is interesting. I mean, this is actually one of those ones where I may talk about it on our TWIV deep dive, because it's this article published in JID, The Potential Benefits of Delaying Seasonal Influenza Vaccine Selections for the Northern Hemisphere, a retrospective modeling study in the United States. So remember, this is not delaying when you get your vaccine, but this is delaying when we have to pick the vaccine. So a couple important background points. So influenza vaccine reduces the risk of medically attended illness by 40 to 60% in the seasons when vaccine viruses are well matched with circulating viruses. When there's a mismatch, not so good. And we also have talked about, if you use a harder endpoint like death and hospitalization, a well-matched vaccine is even better. Well, what's the challenge? Each year, the WHO convenes a meeting in February to select the influenza vaccine for the upcoming northern, and then they get a meeting in September to select the influenza vaccine for the upcoming southern hemisphere influenza season. This involves a whole bunch of cool virological surveillance data from the Global Influenza Surveillance and Response System, where they look at epidemiological, antigenic, genetic characteristic of influenza viruses that have been circulating. The WHO then chooses way ahead of time candidate vaccines that they hope will offer broad coverage against the diverse circulating antigenic groups. But why so much lead time, right? February to predict what will happen next fall and winter? Well, the existing timeline for seasonal influenza vaccine decision-making was established to allow sufficient time for bulk vaccine production, which primarily relies on fertilized chicken eggs. So these egg-based vaccines account for 84.5% of global production capacity for the seasonal flu vaccines. Now, during this many-month gap between vaccine virus selection and start of vaccine distribution, circulating viruses further evolve, potentially diminishing the antigenic similarity to the vaccine antigens and consequently the vaccine effectiveness. Now, what do we have as far as options? The next generation of influenza vaccines, such as cell-based, recombinant, and messenger RNA vaccines, eliminates the reliance on egg supply for production and holds potential to reduce the vaccine production times down to 1 to 3 months, potentially allowing for a better match between the vaccines and the viruses and thus more consistent efficacy. So this all sounds good, but is it true? In this study, the authors aim to, one, identify the past influenza seasons where the opportunity to improve vaccine viral choice existed for the Northern Hemisphere if this rapid vaccine production was available. And two, they quantified the impact of delaying vaccine decisions on reducing the burden of seasonal influenza in the U.S. using a multi-strain seasonal influenza transmission model. Now, their model showed that with rapid vaccine production, revising current timelines for vaccine selection could result in substantial benefits. For instance, an updated H3N2 vaccine in 2014 could have averted up to 65,000 influenza hospitalizations in the United States in 2014-2015.
All right. That brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, or grab it with your favorite podcatcher, or go to microbe.tv/Puscast. We love to get your questions, comments, paper suggestions. You can plug your papers our way. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.